This is the Chapter 8 lecture on vulnerable populations. Excellent chapter. The editors and authors do a wonderful job. There are many groups that are affected by health inequities. They are spoken about in the podcast that you just listened to and certainly described in your textbook as well. So race and ethnicity come into play, as does income, gender, sexual orientation, immigration status, ability level, and many other factors. We see shifting demographics in the United States with the population becoming older and the number of people of color increasing. We also see shifts in those affected by health issues such as non-communicable diseases and a huge increase in income disparities. There are gigantic income gaps, which you will be looking at as well. To understand factors and systems that impact people disproportionately, we need to, first of all, acknowledge that these inequities are everywhere. And we need to embrace health equity, which does seek to address these barriers and break them down. We also need to acknowledge our rocky and sordid history. In this country, there has been a long history of oppression and discrimination, social exclusion, and marginalization. And it is not only historical, many individuals in our society deal with these problems on a daily basis. This is a framework for understanding vulnerability, so there are certainly individual risks that you see listed here. Demographics, health status, your access or non-access to health insurance, and of course, belief systems, health behaviors, culture, but also ecological or environmental risks as well, where you live, your socioeconomics of your community, whether you have access to the resources you need to be healthy, and the social capital of your neighborhood. Your textbook looks at both predisposing and enabling factors. Be sure to read over and understand them. And health need factors. So we have physical, mental, and social being very important to address. There is a growing number of health inequities. So this is a problem in our country, in our healthcare system, and beyond. There's a rise, as we've mentioned, in the number of chronic condition, along with these shifting demographics, and all of this is taking place with a shrinking and strained safety net. Chronic or non-communicable diseases can be treated but not cured, but people who manage them well do well. The issue around them is that not only are vulnerable populations more likely to have a chronic illness, they are more likely to have poor management of that chronic illness or illnesses due to poor access to poor quality of health care. So onward, we have growing income inequalities as well. Your textbook gives hugely alarming statistics on the number of adults and children living in poverty, the number of different demographics living in poverty, the numbers living in deep poverty as well. And this is in a country that has always prided itself on being the greatest in the world. So it's quite a shame. We need to address these inequities for sure, because having less money should not mean that you receive less effective care. We do need to address certain segments of society, including the graying of America, those who are older and have more chronic conditions and have a greater financial burden. We also need to look at healthcare and health inequities in light of what's happening with economics today. The Great Recession is over, but we now are ushering in another recession and perhaps bordering on depression, all at the same time that more and more money is funneled through tax reduction and other stimulus plans toward the wealthy. So, who are the safety net providers? Who are those who look after the vulnerable? Public hospitals have historically done so. Philadelphia doesn't have a public hospital any longer, but we used to, Philadelphia General. We do have health centers, not only the city health centers, but others. And these have taken up the job of taking care of those with fewer resources. So read about the federally qualified health centers for sure. Very, very important in safety net providers, as safety net providers. So these are a few examples of those. There are certainly other health services that become very important. And you're seeing here a patchwork. You really are. In a system that doesn't perhaps holistically take care of the vulnerable. So what are social service needs that become important in keeping people healthy? Food assistance. You can't stay healthy if you are not nourished adequately. We have some programs, they're always under assault, as far as budget cutting. Monetary assistance, for sure, and housing assistance. Look into some of the programs that are available in Philadelphia. The financing of care for vulnerable populations occurs at the federal, state, and private level. Again, quite a patchwork. We have a fragmented delivery system and silo structures. We value volume over quality or value, and we react to disease instead of preventing care. And this holds true for care of the vulnerable as well. So what works? At the end of this chapter, you'll look at some models for care. Certainly care coordination, patient engagement, involving patients, empowering them, team-based care, an integrated system which not only involves hospitals and doctors' offices, but also other agencies in the arena as well. Using data is very important. Now, the ACA did address vulnerable populations. There was increased insurance coverage for many through expansion of Medicaid and improved access to community health centers. There were some major steps forward taken with the ACA, although it certainly wasn't perfect. And now, again, it's under assault by the current administration. So these are the challenges and threats. We still argue over whether health care is a right or a privilege. That hasn't been settled at the governmental level. And the president has altered the ACA, and insurers have been impacted. Great chapter. Enjoy reading it.